Hi, my name is Duquette, and I'm going to be presenting a case study on a 78-year-old male with Alzheimer's disease. So some background on Alzheimer's disease is the most common cause of dementia. About 60% of those who suffer from dementia have Alzheimer's disease. 5.3 million Americans have Alzheimer's disease, and their survival rate is about 4 to 8 years after diagnosis. Alzheimer's disease is due to a buildup of amyloid plaques in the brain. It's usually diagnosed through a mini mental status exam, a mini COG, and through detailed health histories, including the family, who usually notice changes in their family members. Risk factors for Alzheimer's disease can include advanced age, family history, diabetes, female gender, and head injury. Clinical presentations can include memory loss, aphasia, apraxia, agnosia, disorientation, impaired executive functions, and unable to complete ADLs. Behavioral changes can include depression, delusions, hallucination, aggression, wandering, combativeness. Different labs and imaging can be vitamin B12 and folate, thyroid function tests, a CBC, electrolyte, liver function test, a CT, or an MRI. So the case study involves a 78-year-old male with Alzheimer's disease. He's been on Aricept for a year and seems to be getting worse. Family has been reading and would like to start him on Namenda. Patient ES was started on Aricept at his diagnosis 1 year ago. His cognitive decline appeared to slow for his primary caregiver, his daughter, until approximately 3 months ago. Then his family started noticing that he was having problems with ADLs. They're concerned to leave him alone for any length of time. His other medical conditions are currently stable. His past medical history includes diabetes mellitus type 2, moderate Alzheimer's disease, hyperlipidemia, BPH, hypertension, and chronic obstructive pulmonary disorder. He is taking metformin for his diabetes, Aricept for his Alzheimer's, atorvastatin for his high cholesterol, tamsulosin for his BPH, metoprolol and lisinopril for his hypertension, Spiriva and Proair for COPD, and he is also taking Centrum Silver and vitamin D3 as vitamins. He has allergies to penicillin and cephalexin. His allergy was hives. He did not experience anaphylaxis. ES's mother died at 90 years old due to complications of Alzheimer's disease. His father died at 73 years old of a transient ischemic attack. His sister is alive and has been diagnosed with mild Alzheimer's disease at 67 years old. His brother died at 30 years old of a car accident. ES is a retired factory worker. He was widowed 18 months ago, and he has 4 grown children, all living. He lives with his eldest daughter and son-in-law. He denies alcohol or drug use. His daughter says that wander measures are in place at the house. There are locked doors in the fenced-in yard, chemicals are kept locked away, and the daughter is responsible for giving her father all of his medications. ES's vitals today were a blood pressure of 132/90, respirations of 20, heart rate of 75, O2 saturation of 96, and temperature of 37 oral. His blood results from last week are an A1C of 7.1, a fasting blood glucose of 103, HDL of 62, LDL of 107, and triglycerides of 160. His height was 180 centimeters today, and his weight is 100 kilograms. His general appearance is within normal limits, and he is dressed appropriate for his age, race, and the weather outside. His cardiovascular assessment was within normal limits. His respiratory assessment, he appeared barrel-chested. He had bilateral early inspiratory crackles. He had no increased work of breathing while at rest, and he had no evidence of cyanosis or clubbing at the end of his fingers. His neurologic assessment showed weakness in voluntary movement, and he was disoriented to place and time. Our therapeutic plan is to discontinue Aricept. Aricept is also on the Beers list, so this is good as well for his age. We're going to start Namenda XR at 7 milligrams daily. This will be increased 7 milligrams each week until he is at the maintenance dose of 28 milligrams daily. We're going to monitor for adverse effects, including increased confusion, dizziness, headache, diarrhea, constipation, and hypertension. The client's goal is to delay worsening of Alzheimer's symptoms, maintain current functions, and be able to safely remain at daughter's house. Namenda is indicated in order to treat moderate to severe Alzheimer's disease. It is prescribed as It is formulated as extended release or immediate release tablets. The mechanism of action is as an antagonistic in the CNS against the NMDA receptors, which contribute to the symptoms of Alzheimer's disease. The half-life of Namenda is 60 to 80 hours, and the extended release tablets will stay in the system for 1 to 2 weeks. For the immediate release, the initial dosing is 5 milligrams orally once daily. They will be titrated in 5 milligram equivalents at intervals of at least 1 week until he is at 20 milligrams a day, ideally 10 milligrams twice a day. We will be using the extended release, which is 7 milligrams orally once daily, titrating 7 milligram increments once a week until it's at 28 milligrams once daily. Namenda can be taken with or without food. We'll monitor for symptoms of an overdose, including restlessness, psychosis, visual hallucinations, stupor, and change in level of consciousness. We will teach ES's family and caretakers that he will have an increased risk for falls and to monitor very closely until he is stable on his new medication. The extended release form of the medication can be opened and put in applesauce to help with giving the medication. They should not double up on doses if one dose is missed. They should continue on with the next scheduled dose. If several doses are missed, they may need to start a lower dose again and titrate back up. It will take approximately 14 days for the initial medication response to be seen.